So today we'll be seeing a very interesting CT scan of the chest, and this is the CT scan of the chest. Now, what we can see in this particular film is there is significant involvement of the lungs, that too around perihilar region. So this perihilar region is typically involved in this image. So we can see here that there are whitish, or what we can call it as hyperdense nodular opacities. Nodular in the sense you can see the nodular opacity will be like this dots. So this type of dots, what we can very clearly see is here. So there are very fine, thin dots or nodular type of structures, specially involving this area. This is the area where it is involved. So as we know that this is the pulmonary trunk, this is the pulmonary artery and pulmonary trunk, and this is the pulmonary vasculature. Basically, this is the way through which the pulmonary vasculature goes. The pulmonary arteries, pulmonary veins, and bronchi, they all grow from this side. So this is all pulmonary bundle. So this is pulmonary vasculature, and whatever involvement is there, it is all around this area only. Here also, what we can see, compare, we can clearly segregate this area. So this much is much radiolucent, means we can very nicely clearly say air, and there is no much involvement, like there is no infiltration, there is no any whitish or hyperdense involvement. The same thing here, what we can see is this part is more of a whitish structure, hyperdense structure, or there is involvement, but not here. This is completely spare area. Same thing here, that what we can see is this area is involved, but the outer part is totally spared. This area is totally spared. So we know that whenever there is perihilar, because this is the hilum, this is the pulmonary hilum, and this is the pulmonary vasculature. This is bronchi. This is the main bronchus which is growing. This is left bronchus. This is right bronchus. Basically, this is radiolucent structure. So in this image, there is clear-cut involvement around the hilum, and it is sparing the outer portion of the lung. It is a very, very typical feature of pulmonary edema. This is the very typical feature of pulmonary edema, because in pulmonary edema you'll be having a perihilar involvement. So pulmonary edema is a feature of acute. It is usually a feature of acute decompensated heart failure. I mean, whenever there is sudden heart failure, then only you usually almost always get the pulmonary edema. So whenever there is acute heart failure, you can also see for other signs of acute heart failure like pleural effusion. So pleural effusion is one of the most common finding of acute heart failure or heart failure. So we know pleural effusion is more of a collection of free fluid in the pleural cavity. So pleural cavity, as the patient is lying down, this is the back of the patient, because we can see the vertebra. We can see the vertebra here. It means the patient's back is here. So whatever collection of pleural fluid is there, it has to be in the dependent part. So this is the dependent part. So we can very clearly see that the patient has pleural effusion. So this is the pleural effusion. There is very thin rim on the left side, and there is pretty good effusion on the right side. We can see the same thing in other slides also. We can see this is air. This is all air. This is very hyperdense bone. Obviously, this is bone. This is bone. And in between the bone, the lungs, is pleural effusion. So this is all pleural effusion. So this is collection of pleural fluid or free fluid in the pleural cavity, that is pleural effusion. This also, here is the bone, here is the lungs, this is the margin of the lungs, and in between the bone and the lungs, there is collection of free fluid, that is pleural effusion. So bone will be very much white or hyperdense. air will be black, and the whitish structure, not as dense as bone, and much more whiter or kind of radio opaque structure on CT imaging is water or pleural fluid. So this pleural fluid is there, means there is heart failure. We can also see fissural effusion. What we can try to see is fissural effusion, and we can notice fissural effusion if it is there, because fissural effusion is one more sign of pleural effusion. So what we need to find is effusion into the fissure or pleural fissure. So I'm just trying to find. Okay, it is not an ideal location to see. So I'll definitely show that. Apart from that, the other DDs for this type of involvement is either infective. It can be infection, it can be bilateral infection. For example, a COVID-19 involvement. But in COVID-19, what you get is ground glass opacities, and these are almost subpleural, means you can get the ground glass type of opacities, but not in the center, but in the peripheral region like this. You will get the lesions in the center as well, but the main lesions will be almost always subpleural, patchy, bilateral involvement. If it is very much less involvement, it can be unilateral as well. But the typical feature is usually bilateral, subpleural, patchy involvement. Apart from that, a consolidation is almost always dense, means you won't get this type of consolidation. Consolidation or pneumonia usually almost is very much dense, and it will only involve one part of the lung. Usually it will involve one patch or one part of the lung. So this will be like pneumonia. If it is multilobar pneumonia, it may involve multiple lobes, but it will be in a continuous fashion, and it will involve usually from base to apex or from the periphery to center. So it won't simply involve only central part usually. Other things which can be there is ARDS. In ARDS also patients can very rapidly worsen. But in ARDS usually patients always have some pulmonary symptoms like cough, fever, weakness, tiredness, lethargy since few days, 4 days, 5 days, 6 days, 7 days, and then patient worsen. But whereas in pulmonary edema, patients usually worsen very, very, very fast. And most of the time, to to suggest whether this is really pulmonary edema or not, you can simply do some tests. Like as I told, that pulmonary edema is basically heart failure. So if it is heart failure, the patient's NT-proBNP will be much higher. So NT-proBNP, if it is high, if on echo there is reduced EF or reduced pumping, presence of positive troponin T or troponin I or CKMB, this test highly suggests that that is pulmonary edema. So meet in the next topic, a very interesting topic. Thank you.